Good evening and welcome to the QRME Rural Medicine Grand Rounds. I'm Dr. Lucy Ingram. Tonight we have, for our first case, we will explore a topic in urology. On our panel tonight we start with Gary Logan, who's a clinical psychologist in Toowoomba. We have Dr. John Hall, one of our experienced rural GPs from Oakey. We have Dr. Jacob Gleeson, a urologist from St Andrews here in Toowoomba. And we have Julie Westaway, a clinical nurse consultant in Urogynaecology, who also works for Home and Community Care. Is that right? Can we all please welcome our specialist and expert panellists? All right, for something a little different tonight, we have our case presentation which has been pre-recorded by one of our rural registrars. Dr. Edan Buxton will now present a case in urology.
Good evening everybody. My name is Edan Buxton. I'm the QRME registrar for Laidley and it's my honour to present the first grand rounds of the year for you tonight. So the theme is urology. And the topic that we are going to look at is in relation to the prostate and the sort of symptoms that people present with. It's not a complicated case by any means, but it's one that you quite commonly get people presenting with, and it's more about sort of conundrums associated with waiting for management and other things that you can do in between. So hopefully it sparks off some good conversation. We can all learn something from it. So to get started, so the patient tonight is an 84-year-old male. He presents to the GP, a new GP who hasn't seen him before, with 6 months of worsening urinary symptoms. He's had nocturia 5 to 6 times per night, difficulty initiating void, poor stream, trickling with low volumes voided, and sensation of always being distended in the suprapubic area. Importantly, he's had no symptoms of hematuria, no fevers. He's been systemically well otherwise. So in terms of past medical history, he did have BPH diagnosed 6 years earlier, based on similar symptoms to these, but not as severe. He had no initial treatment for that, and a normal PSA when he was first seen for these, but he hasn't had a PSA since this initial one that was done 6 years ago. With worsening symptoms, his previous GP started him on Duodart 2 years previous. He's also had some previously high blood pressure that was treated 10 years ago, but he doesn't remain on any treatment for that now. He hasn't been too compliant with the GP over that period of time, and he hasn't really had any other medical issues that have been followed up or investigated over that last 10 years. His only other important history that he informs you of is an appendicectomy as a child. So medications he's on at the moment, just the Duodart, so dutasteride and tamsulosin. He takes 1 tablet of that each day. On examination, all of his observations are good. His abdomen shows no obvious suprapubic distension and soft and non-tender. You do a DRE and he has an enlarged prostate, but you can't feel any specific lesions in that prostate itself. So the impression or the lines that you're thinking along initially is that it's most likely a worsening of his BPH, but that he also needs an update on his screening type bloods. And it's important to, considering he hasn't had that PSA in over 5 years, to get that done again. So you organise some bloods for him to have. He has a PSA, full blood count, ELFT, fasting cholesterol and blood sugars, and you're thinking to yourself that urology referral is probably appropriate after you getting back and have a look at his bloods. So in terms of a second consultation, you see him 4 days later. Quite a bit's happened since the first time you saw him. The night before seeing him, he was seen at the local country hospital for lower abdominal pain, secondary to acute urinary retention, as defined by the doctors there. An IDC was placed, which relieved his symptoms and has been flowing well since then. But he's been sent back to you for further management, with no further referrals or investigation planned by the hospital. However, prior to leaving, he did see the hospital nursing staff there, and they talked to him and educated him about how to use his catheter bag and other symptoms associated with the catheter or the catheter bag that need review. So importantly, you've also got his initial results back from those bloods that you did. His PSA is very high at 87, with his other bloods showing a full blood count that's quite normal. A UNE is showing normal renal function, and his calcium and other electrolytes are normal, as well as his fasting cholesterol and fasting blood sugar also being normal. So in light of this elevated PSA, you take some further history. He's had no bony pain, no recent weight loss. He's been tolerating good food and fluid intake, no night sweats either. He lives with his daughter and her family out the back of their property in a granny flat. He's financially independent. He has no private health insurance. He's currently continuing on Duodart, and he generally just sort of says that otherwise he feels as though he's doing quite well, and his capacity to function at the moment is quite good otherwise. So you decide that you should refer him to the Central Urology Department. After referring him in, you get a letter back saying that he's a Category 2, and the expected wait time is 3 to 4 months. So you undergo some more education with him on regards to how to deal with the indwelling catheter, indications for it to be changed, and symptoms that need review both urgently and just the next day. You decide that you'll review him every 2 to 4 weeks until he's seen by the urology department, and go from there. So in terms of further discussion points, I tried to break those up into a few different categories, and they're designed to be other things that I would have been thinking about, or that I would be thinking about in regards to what else needs to be done in that period of time before he is seen by the urology department. And that's what this case is supposed to be about, for the patient that doesn't have private health insurance, that you're going to have to manage by yourself with this issue for a period of time. Obviously there's other people to talk to, but in terms of a learning exercise, I thought these points would make an interesting discussion and a good learning point. So in terms of the actual points, what he's on at the moment, is it appropriate that he continues that? And what else should we be looking to do prior to him being seen by urology? So in terms of the Duodart itself, should he continue on it now that an IDC is in place and working, functioning well? Is it safe for use with a PSA that indicates possible prostate cancer? And importantly, in terms of what the PSA reading is at the moment, how much does Duodart actually raise PSA? Prior to his urology referral, and this is looking into what further investigation should be looked into that's going to streamline his process with urology. So considering he doesn't have any active symptoms that you can define at the moment of metastatic spread or metastatic cancer causing other issues, should we be doing staging scans prior to his urology review? If so, what should be scanned? How should it be scanned? Should a prostate ultrasound be undertaken prior to urology review? And is there anything else that will streamline and make his initial appointment with the urology team more effective for both himself and the urologist? The other thing was his IDC care. We've all sort of managed catheters as in inpatients, but in terms of managing them out of the community, how often should an IDC be changed in the community? And how much does that vary if it's asymptomatic? And if there isn't, a capacity within the practice that I work in to have the IDCs changed, or if we don't have them, where can they be changed? Is the local hospital the most appropriate place, or will other people do that? And are there any other points that other people think are valid to discuss whilst this patient is awaiting treatment with the urologist for that problem?
Great presentation there from Edan. Well, if we can start the discussion perhaps with you, John, what are your first thoughts on hearing that case of that patient?
I guess a little bit worried about how long this patient's gone on, and I think part of that is patient compliance, that he's sort of been in the community for a while with those types of symptoms and possibly not had some of the investigations like the bloods that he should have had earlier. But as I say, I think that seems to be more of a function of the compliance with this patient at the time. I guess too, I would normally do an ultrasound as a part of the workup, as part of my GP care in that process. So there's sort of the two things that hit me straight away. I think there is lots of complexities in the community around catheter care, especially in the bush. We often have the luxury of having a close relationship with our hospitals. So I know that often GP clinics don't necessarily carry a full range of catheters or catheters at all in some cases, but we work fairly closely with our hospital out at Oakey, providing that sort of care and often share equipment and materials and work closely with the community nurses as well. So I think in some regards in smaller country towns you've got the advantage of had that closer relationship with the hospital and equipment sharing and that type of thing. But they're the sort of main points that I guess I picked up on initially hearing that.
And sorry, you mentioned an ultrasound. Would that be a KUB, and would you do a pre and post, or what kind of ultrasound would you order for the registrars?
Well, obviously after having done a thorough examination and making sure you did a good PR to check, I would mainly be focusing on the ultrasound of the prostate. I'd be more concerned about the kidneys and higher up if there was any issues with the renal function. So, but I think I normally would just be ordering an ultrasound and looking at the prostate in that sense initially. Yeah.
Great. If I can come to you, Jacob, there was quite a few questions there sort of for the urologist and what can be done in the outpatient setting in preparation for that urology review down the track.
Lucy, I just want to make one comment. My first feelings with this case is this man may not have prostate cancer. What's happened is he's got an acute deterioration in his urinary function and a PSA of 87, and to me that raises the possibility of prostatitis as a diagnosis. So I'd be thinking along the lines, if this man was coming to me, are we dealing with prostatitis or are we dealing with advanced prostate cancer? And the first thing I'd say to registrars and GPs is it's very difficult for me to work that out, but the thing I'd say is trust your finger. You know, if this man has advanced prostate cancer, his rectal examination should be grossly abnormal. If it's a soft, benign feeling prostate, I'd be thinking, hey, we could be dealing with a guy with prostatitis. His urinary function's deteriorated quickly and he's got a high PSA. So my first step with a guy like this would be to put him on antibiotics, something like norfloxacin for 2 or 3 weeks, and repeat his trial avoid, and also repeat his PSA. And John's point's valid. I mean, if he'd had a PSA done 3 months ago and it was 6, again, that raises the possibility of this being prostatitis. It also raises the question, should we be screening 84-year-olds for prostate cancer? And that's another contentious issue. So with regard to the questions, the first thing I want to say is, we have to consider prostatitis and treat for that and exclude that as a diagnosis. The questions asked surrounding Duodart, the first thing is you'd all be aware that unfortunately Duodart has to be initiated by a urologist. And the reason for that is that a large trial run in Europe called the PCPT trial, or the Prostate Cancer Prevention Trial, was a prospective population study done whereby men were put into a placebo arm or a 5-alpha reductase inhibitor arm, and they were followed over time. They were biopsied and screened initially and then at the end of the trial, and they found that men who'd been on 5-alpha reductase inhibitors were more likely to have cancer on their biopsy post-treatment. We think that's a detection bias in the study. Because 5-alpha reductase shrinks the prostate down, it became easier to detect cancer. But there is a cloud surrounding whether this drug is a promoter of prostate cancer, and that's why men who are started on it or initiated on it have to have a good prostate cancer screen with a PSA test and a rectal examination. So that's the lead into why Duodart is urologist initiated. The second question about whether the patient should still be on it, if the patient is going to have another trial avoid, you know, antibiotics and trial avoid, I would keep them on it. If we've decided that they are off to the urologist for management, then there's not a lot of point. They're probably going to head towards a TURP. So they were the issues surrounding Duodart. The other questions I think related to what to do in the lead up to review.
Yes.
I think if we've done a second trial avoid on antibiotics and that's failed and we think prostate cancer is very likely, I agree with John, I think an ultrasound is very useful. What that tells me is what size is this prostate? Is it 150 grams or is it 30? And that gives me a bit of a lead in as to what sort of operation I need to do. It also covers off the kidneys. Is there a bladder stone? Is there other complicating factors? So I think an ultrasound is useful for us before the patient comes to us. I've got to admit, 3 months between referral to clinic's a long time, and I'd like to think we don't have that delay. If a patient's got a catheter in, I think they should be reviewed at the 4 to 6 week mark by us before the catheter needs changing, and we try to do that here in Toowoomba. And I think if we've decided prostate cancer is very likely, very hard, knobbly prostate, PSA is very high, we don't think we're dealing with prostatitis, I think a bone scan in this man is very useful. So that's my take on it.
Can I ask, with the differential of prostatitis, what would be your ideal workup there, or would you just treat empirically?
I'd treat him, if I had a soft feeling prostate that was enlarged and a guy whose renal functions deteriorated quickly, I'd just treat empirically. 4 weeks of norfloxacin, keep them on their Duodart, repeat their trial avoid and repeat their PSA.
Do you expect tenderness with the rectal?
Not always, no. It is a common sign, but not always. A lot of guys don't get, well, you know, most guys nearly leap off the bed no matter whether they've got prostatitis or not. So I find tenderness a hard thing to gauge. But no, I find that you can have guys with prostatitis with not a lot of tenderness.
And what's the sensitivity of like just an MSU in that situation?
Yeah, usually it's pretty good, and that's another good thing to do when the catheter's going in is you should have at least white cells in the urine if the prostate's infected. You should. But again, you can get a chronic prostatitis that's sort of quite deep-seated, and there isn't a lot in the way of investigations that's useful. So I think it's useful in a guy like this just to treat him for 2 weeks. What have you got to lose? You're going to wait 4 weeks for the clinic appointment at least anyway.
Yeah.
With causative organisms, is there any point in checking for things like chlamydia or gonorrhea, your sexually transmitted infections?
I think if your pre-test probability is up, you know, if you're dealing with a younger man who, you know, has multiple sexual partners, yes. But prostatitis as a complication of an STD is not very common. It's usually bacterial prostatitis, and in an 84-year-old, I don't think I'd be too going to that. Yeah.
So can I ask you, Julie, this chap now has an IDC, and you know, it's going to be a few months before he may be seen by the specialist, so presumably that may be remaining in for that time, if not passing a trial avoid. When a patient comes to you in that circumstance, what kind of thing do you go through?
A lot of families ring in because even though they've been given the information by the GP or by the hospital about catheter care, they're in a state of flux, and they go home and they pretty well forget everything that they've been told. So one of my role is to reiterate those facts and just find out what they are doing. And you know, a lot of patients put together their own home remedies, and you know, we see it all the time. And you know, so you really do have to consider that they may not have taken all that information in. Catheters in rural areas, as you were saying before, you know, they're really difficult to be able to purchase for people who don't know where they are. And even a lot of nurses who work in rural areas don't actually even know where to actually get products for their patients. Generally, if it's a short-term catheter, there's a number of companies like Convatec, Coloplast and Hollister that provide discharge packs, which the GPs might not even be aware of. And it's just a tear-off sheet, and you put the patient details on it. You put down what sort of leg bag and night drainage bag they need. So if you want a 500ml, 700ml bag, so you look at your patient and find out, you know, they've got skinny little legs, or, you know, if you've got someone who's morbidly obese, then you work out what type of straps you're going to need for your securement. And they'll actually even provide cath fix for the actual catheter as well as your leg securement. And they'll give you 1 to 2 sets of bag, depending on which company. And one of the companies actually will even supply you with a Reline catheter for your first catheter change. And it's all free of charge, and they'll just deliver to the patient's door. If you haven't got, if you've got a patient with a longer term catheter in, then there's a local company, Brady Industries, that will actually, you can go and buy one off of them. That will be expensive. Your catheter is going to be about $35. The bags, start to be expensive because these patients should be changing their leg bag every week and their night drainage bag. And that's the other thing about is, not sort of having your closed drainage system being disconnected. A lot of patients are told to put the night drainage bag onto the catheter and take off the leg bag, and then next morning just change them over. They shouldn't be doing that. The leg bag is something that's very secure to them. It stops them from dislodging it, and it stops them from getting infections. So we get them to keep that leg drainage bag on and attach the night drainage bag at night, and get them to secure that night drainage bag in a bucket or some such thing if they haven't got a holder. Next morning they disconnect their night drainage bag and they flush that through. They can use a little mild vinegar solution and hang that up, but the leg bag stays on. At the end of that week, they then need to disconnect that whole thing and put a new set on. Jacob, I know, has previously sent some of his patients home with flip flow valves. So if they want to go out into the community, want to socialise, this guy might have his own little shed, if he's on the, a little farm, he might be, and we find a lot of country guys are still doing their own little things in their sheds. They just put a little flip flow valve on and they don't have to have the worry of the bag, and they just go out the back of the shed and empty out their bladders every 2 hours. But they have to do that by time. So, they may not actually have the feeling. So if they've had this problem for quite some time, they may have had really large bladder capacities and lost a lot of sensation. So with that, they need to time their emptying of their bladder. So you say every 2 to 3 hours, you need to go out to the back of the shed or go to the toilet and open your flip flow valve out to empty your bladder. But at night time, you then again need to put on your leg drainage bag. When you were talking before about catheter changes in the community, I know that a lot of elderly patients find it very, very expensive if they're using a domiciliary service for their catheter changes. They charge them for a catheter kit to change the catheter. They're $35. Their catheter, another $35. They charge them for the visit. They charge them for the leg bags, their gloves, their gowns, everything. And, next minute the patient's got a bill for well over $100 for their catheter change. If you've got a larger prostate, it might be more difficult for that domiciliary nurse also to change that catheter. We've got provision at the hospital for a patient who's there to come in as a day patient to ADTW, and that would be with something Jacob would be recommending possibly too if they've got a difficult prostate change. But if it's okay, then the GPs would in their own practice. But I know that from experience, there is very few GPs out there in the community now who are doing catheter changes. It's very difficult to engage the services of a GP. So if you're doing it, really happy about that. So catheter care, it's something that you have to follow up on. You can't expect that your patient's going to get it the first time. And it's reiterating the facts and talking to the other family members that they understand and they're supportive of it as well, especially if you've got an 84-year-old. They may not remember all the facts. We provide them with a home management of a catheter fact sheet, so that they can actually do their little tick-offs as well. And we give them phone numbers so they can ring into us at any time. If it's short-term catheter, they're not eligible for state or federal funding. Okay, so things like medical aid subsidy scheme or continence aid payment scheme are only for patients that have got permanent or long-term catheter use. And as Jacob said, this actually is a patient that's not fully investigated yet, so we don't actually know what's going to happen or if they're going to have a TURP. And then if they've often heard about, the rebore, as they call it. That's what they'll tell me on the phone. Am I having a rebore? And especially if they're country guys, they know those terms. And that's when you start to get a lot of distress happening because they're worried about whether they're going to be leaking when they get home. They're worried about, what the long-term consequences. Have I got cancer? Have I not? And they're all things I can't answer for them because that's, further investigation. But then also in the long term would put them in touch with the prostate support group. They're a group here in Toowoomba. But from a country perspective, Gatton's got their own prostate support group now, and Stanthorpe's having their first meeting in the next couple of months. So there are some country areas that are starting to develop their own prostate support groups. But even if you are out, say in Oakey, your patient can still ring in and get support by those people, and they do home visits to patients and whatnot. They're very, very good supportive. But you know, psychologically, it has a huge impact on men, that is for sure.
How do people access those services? So both the continence care services and the patient support services.
Okay, so say though we're needing either short or long-term support with the Continence Advisory Service, that's a home and community care program. All they need to do is self-refer. That Jacob can refer in or a GP can refer in. Referrals come from everywhere. They might come from his daughter, they might come from himself, might be a nurse in the country practice, you know, ringing in. So they don't generally need a GP referral. So anyone can refer in, and it's a free service because it's part of Queensland Health.
And you did mention some of these psychological issues, and I was going to ask you, Gary, with regard to this case. This is a case where the diagnosis is not yet certain, and there's a lengthy wait until sort of seeing the specialist to try and find out. And in that, you know, is in the back of the mind, is it cancer, is it cancer? Sort of, how would you sort of approach supporting a patient in that kind of circumstance?
Yes, I was just listening to her and thinking there's a lot of uncertainty in this. And you know, uncertainty is not something the human mind deals well with. And we kind of have a bit of a default button that says, you know, if uncertain, go for the worst possible explanation. It's a bit like, you know, don't jump into dirty water. There might be a rock. You know, it's a kind of an evolutionary phenomenon of assume the worst. You know, so you're gonna, you know, like I'm just listening to this and thinking, yeah, well, there are lots of alternatives, but yeah, the kind of the thing I'd be looking for would be, you know, what meaning is he giving to it? You know, because humans don't experience the world as it is; they experience the world as their mind says it is. And you really would need, you know, like say from a psychological point of view, you know, I'd like to, you know, like I'm a private practitioner, so there's those, we have like an hour that we can sit with people and to, you know, first of all, you know, kind of just explore how is he making sense of this? What's his take on it? The thing that stood out for me though too with the presentation was that he's, like while he might be on a farm with family, he lives alone. And, you know, facing your mortality alone is a very frightening thing, you know, for anybody. And it's not necessarily a mark of your maturity. It's sort of like the mind has a way of making you think you're safe. And we need that to function. So when people experience a major trauma, one of the psychological phenomena is that sense that I'm safe in the world gets shattered. And so in sitting with people who have, you know, heard very, you know, difficult news like that, there is a really listening very carefully to, you know, how this person is giving meaning to this. And in my experience with people in these circumstances, you'll hear a lot of rational stuff to start with. And you need to validate that, because they'll be often saying what they think the professional wants to hear them say. You know, and it can take a little while. Go, well, that's really great that you've got those, you know, really, you know, those thoughts. But I'm just wondering, you know, is there anything else going on there? And you use that term at the back of the mind. And I kind of talk about the kind of thoughts that a person has at, you know, midday when they're in their shed versus the thoughts they have at 3 o'clock in the morning when they wake up and the demons are out. And that's a tough time when you've just, you know, had a consultation with a doctor who said, look, you know, like you've got these symptoms and you've got these readings. And one of the, you know, very real possibilities is that you have, you know, like a life-threatening cancer. Now the time on it, you know, is uncertain and the uncertainty of it heightens anxiety. And sometimes with clients we'll try to help them differentiate fear from anxiety. Fear is when the mind has a very definite sense of threat and it can target it and see it. So I fear the man with the knife. I can see it and there's the man with the knife. And my mind can formulate a response and it gives us a kind of sense of control. But anxiety is kind of like, it's like fear and physiologically it looks the same. But Anxiety is a phenomenon that is much more intense, and it's often when there's this ambiguity and this uncertainty and there aren't quick and easy responses. So anxiety is more like, thinking you're on an island, all of a sudden it sinks and you're now in the middle of the ocean and there's no land in sight. And you don't know what's under you, you don't know how far it is to safety, and you're all at sea. And it's a very gripping and different experience. And so one of the things for a psychologist to help a person do in that situation is to help them clarify, what is it that you're afraid of? Let's name it. Let's give names to this. And that uncertainty with the urologist is understandable, but it will make it hard for him to give names to his fears, like, and what do I have? And that 3 months is a long time. That's true. It is a long time to sit with, I may have a life-threatening, illness. And the aloneness, the fact that he's alone, I'd be concerned. I'd be, like the sorts of things that I'd watch for would be, what are his coping strategies? So as a psychologist, I'd be saying, well, look, in your life, like you've made it to 84, so you obviously have developed strategies. How do you deal with fear? And I'd be, if all he knows to do is to be busy, which some guys and say farmers, then of course if that busyness is compromised, then he has no strategies. And so from a clinical psychological point of view, I'd be probably wanting to sit with him, talk it through, get him to articulate what his concerns are, and then try and help him problem solve, like clarify and crystallise his fears. The main fears in my experience with guys in this situation is the fear of the consequence to the people they love. Like often there's not that immediate, oh my God, it's me, it's the people that love me will be upset. Now this guy doesn't have a wife with him by the look of it, so he may not have that concern. But if he did, that would be a major concern for him. Would she be taken care of? Is she going to be okay? These are the sort of thoughts. The other one is the pain. Like people will often have a kind of a realisation that, and we can easily Google things these days, and so people can feed their imaginations with information. And so it doesn't take long to see that if you Google it, that prostate cancer metastasises more often than not, it's going to go to the bone, and that can be a very painful experience. So talking that through with the person, and the other fear, of course, is well, what comes next? If I die, what then? And some people have very clear spiritual, religious beliefs that give them guidance and comfort, and they can seek support from a church or a priest or something like that. But other people are very uncertain, and that uncertainty, they need to talk through. And a lot of people don't have language for that stuff, and so really sitting with them and really talking through. Okay, well, what does life mean, and what do you think is coming next? And in that is a very important conversation, which is about, like, what did my life mean anyway? Like here I am, I'm 84, and it may well be that I don't have much left. And one of the things the mind will want to do in that circumstance, and this is kind of whether you're dying in the immediate or not, but certainly having a possibility of death heightens and accentuates it, is the need that a person has to really talk through their life and make sense of it, find a meaning in it, maybe seek forgiveness for things that didn't go well, to get clarity. And this sort of stuff takes time. And then teaching them skills. And I've found that some of the skills that have been most helpful for guys that I've worked with in this circumstance, and they've come back and said, that was the thing that helped me the most, is that ability to just appreciate the moment. That I've luckily got a balcony, and I'll take guys out and I'll go, okay, there's all this stuff going on in your head. And look, you might be dead in a year, 5, well, I don't know. But the thing is, this moment will never happen again. And if you're totally consumed with your fear-based thoughts, you will have missed it. And it's very powerful. It's simple, but very powerful. So there's a few thoughts. I think we could really, from the psychological point of view, we could sit here for a long time talking about what's going on. But there's a few thoughts.
And I wanted to ask you, John, with this 84-year-old man, he's been very independent up until now, and now he's got an IDC in, he's having to do changes to that. Is this something that is going to be the beginning of the end for this chappie, or is this going to have a major impact on his life into foreseeable future, and how do we approach that as GPs?
For sure. Look, I think the points that Gary's touched on are really pertinent. These guys are often very, very independent. They're often non-compliant because they're in control of their own lives. They don't see that as non-compliance. They see it as them having control over their own lives. I've seen multiple sort of farmers and guys on the land that will ignore serious medical problems. And I'm not saying that in a critical way, but it really is a mindset sometimes that they've just got to get the stuff done. They've got to get the harvest done. They've got to get this done, and that's just the ultimate priority in their lives. And it sounds a bit cliched, but I've certainly seen lots of it. And I think that's the same for this guy. And this is something that's completely out of his control. If you can't urinate and he's going to be in severe pain, that's something that stopped him in his tracks. He's got no option. He has to go down this path. He can't, with an infected hand or something else like a cellulitis, they can choose to go off and bear it and hope for the best. But this is certainly something that's just going to stop him in his tracks. So I think that is going to be confronting. But equally, I think our role as a GP, and I think we can mitigate some of this psychological stress by actually using proper language when it comes to how we're explaining things to them. This, as Jake said, this may not be a serious diagnosis of cancer. I think it's our job as GPs to really demystify the term cancer, and we deal with lots of non-life-threatening cancers and dysplastic changes across the spectrum of the human body. And one of the things that I do with my skin cancer work all the time is make it very clear that, yes, this is a cancer, but these are not the sorts of cancers that are going to kill you rapidly, and really distilling that out for people so that they understand that there are changes that happen that are termed cancer, or we use terms like tumour and this type of thing, but it doesn't always mean a death sentence, and being crystal clear about that, reiterating it, making sure that you say that sort of stuff in front of loved ones, that you reiterate it, you get them back and talk to them again, so that, we do our best to make sure that they don't walk out of our room thinking that it's a death sentence, thinking that something that potentially is completely benign is a problem, and couching it in language of, this is something where there's a chance it could be a problem for you, but we have to go through a process where we investigate it properly to be on the safe side, but, and really reinforcing that point that, potentially isn't going to be as catastrophic as he thinks. And I think especially in this case where we know a lot of older men die with their prostate cancers, not of their prostate cancers, knowing that the high rates of slow-growing, indolent sort of prostate cancers in the community. So I think that's a really important role for the GP. We get lots of patients coming back to us from busy specialists where they don't have the time or they don't have the capacity to get them back more often, where I think it's really an important role of ours to reinterpret and reinforce some of those messages. I think that'd be my spin on that.
And Jacob, what do you think?
Yeah, I mean, I support all the thoughts of the other panellists, but and John's point's right. I mean, as a specialist in a public clinic, we have so limited time to deal with all these issues, and we want to maximise their time with us so that we can diagnose, investigate, and manage the issues at hand. And those other issues, such as how the patient's coping and those things, we really do rely heavily on the GPs, the clinical psychologists, the nurse practitioners to deal with those issues for us. So that's vitally important, and it's something we have to defer to our other colleagues for. I think John's point's very valid. Prostate cancer figures are that only 1 in 10 men diagnosed die of the disease, and so I sort of always tell my patients that this is, yes, it's cancer, but it's not the sort of cancer you hear about in the news that's going to come and grab you in the next few weeks. This is a slow-growing cancer usually, and we have multiple points of ammunition we can fire at it before it starts to consume you or give you problems. So that's a really important point. Can I backtrack a little bit?
Yeah.
One of the questions was about Duodart and what it does to PSA, and I think that's really important. It doesn't raise PSA, it decreases PSA. So Duodart has a 5-alpha reductase inhibitor, which is tropic. 5-alpha reductase is tropic to prostatic glandular tissue, so it shrinks that tissue down and that tissue doesn't produce PSA. The rough rule of thumb is that over 6 months it should halve the PSA. If it doesn't halve it, then you have to be suspicious about the possibility of cancer. So that was one of Edan's questions that I missed.
So in light of that, does the PSA of 87 look more suspicious or less suspicious? Should it be 160?
Well, I guess the point is if this man has cancer, yes, it could be 160 if he's been on Duodart for that long. But again, I hark back to trust your finger. If he had a PSA of 160 due to cancer, blind Freddie, you'd be able to feel a horrible prostate.
That's great. Any last thoughts there about his?
I fully agree with what the other panellists have said, and I think one of the main things is that in the community, it's about communication between health professionals. You know, I don't work in my own little silo. I really very much rely on other people like, you know, occupational therapists and physios. So if he was to have surgery, there's been no mention, you know, about whether he's got any arthritic. So even though he hasn't been seeing his GP, doesn't mean he's not a farmer that's just ignored his arthritis. And if he's going to have a surgery, you know, it's working with those people to see whether it's going to be a safe environment for him to go home in, you know, working with urologists like Jacob and the GPs and psychologists. You know, you can't work in your own little silo with these people. And, you know, again, it's sort of looking at all of his care at home and, you know, is he not just got sort of some major constipation as well, causing other issues with his prostate, with his bladder, because that's very common, especially with guys and farmers, not always been great drinkers and had long-term prostate and straining. And, you know, if he's going to go into surgery, you've got to have him that he's got optimum health. So part of my role is that preparation for theatre and talking to them about if you're going to be having surgery, if Jacob was to get back to me, you know, how we're actually going to manage that pre-surgery, post-surgery, and then it's the counselling afterwards, things like pelvic floor muscle exercise, retraining, you know, is he going to be open to that, not open to that? You know, you can't assume just because he's 84 that he's not. Yeah, you know, I've got an 84-year-old, actually he's 87 now. When I first saw him, he had a catheter in and, you know, had BPH, and one thing said to me, he said, well, this thing's got to go out. You know, I've only been married 15 years. You know, like, how am I going to have sex with this thing in? So you can't assume because they're elderly that they actually don't have, you know, a full sexual life. So, you know, you sort of have to, you know, talk to them about all these things. And these are their fears that, you know, we're talking about before. And they often open up to you as time goes by. They're not going to be there on the first time you meet them. But, you know, I'm lucky that I have the luxury that I will see these people a number of times and, you know, work with other health professionals. So I think coming from a team perspective is really, really important for these guys.
Can I make one other comment? I mean, there are also a number of other options. A lot of elderly patients find catheters a horrible idea, and as GPs, it's nice to think of the other alternatives. So Julie's already talked about flip flow valves, which is one thing that takes a lot of stress away from them if they don't have a bag. The other thing is they can be taught to self-catheterise. It's a bit radical, but Julie would know that some people think that empowers them. It gives them the option of not having a catheter in and they have the control over it. And that's something that we don't often think about, but that's something that Julie and the team can teach them, and that's an option for people who may have to wait for surgery or who have a long-term problem.
Brilliant. Alrighty, we might throw it open to our studio audience for any amazing questions for our case tonight. Yes.
I was interested in a statement you made earlier, Jacob, about PSA screening in an 84-year-old. I got to say, I wouldn't have called doing a PSA on this guy screening, because I would have thought that if he hadn't have done a screen, the registrar would have copped a shellacking from the hospital or whomever he referred to for not doing an adequate battery workup. So I get the issue about PSA as a screening test, but I'm not sure this is screening.
No, absolutely. I completely agree. This circumstance isn't screening, and this is very diagnostic and very useful. I guess, though, you know, it's controversial. If he'd had a PSA done 3 months earlier that was 5, that's very useful because that tells us that this is almost certainly prostatitis, you know what I mean? Whereas if he hadn't been screened at all, we're a bit in the dark. Now, but if he is screened, are we going to put him through a whole lot of tests and ramifications for a disease that may never have any impact on him? So this is a controversial problem. In this circumstance, though, absolutely, I don't think this was screening, and PSA test in this man completely appropriate.
Look, I was going to make another question as well about where I work at Clifton, we do a lot of catheterisations, as John said, and I think it's a great point that you made about how healthcare access in the country is actually better in these cases, which is a nice thing to remember. Occasionally, rural healthcare is actually better access. But the problem arises when you get these ones that are difficult to catheterise, and what do you do then when you're an hour from your user-friendly urologist? And how do you feel about what's the next step when you get into that sort of sudden moment?
Very difficult question, and there's a few. I guess there's a few things. I think you can try a larger catheter or a smaller catheter if that's possible. I like to use plenty of lubricant. If all of those things fail, if you're trained in suprapubic catheters, brilliant. It's important to assess the patient as well. If they're not in pain or discomfort, you don't need to put a catheter in. If they are and you can't put a suprapubic in, another option is to get a big spinal needle or a big cannula and just decompress the bladder. And that'll buy you some time. That's my advice to a doctor stuck who doesn't know or isn't comfortable with suprapubic. I say get a big cannula and stick it just over the pubic symphysis and just drain out as much as you can, and that'll buy you 5-6 hours until the patient gets moved.
I was going to say, if you can't get in permanent catheter because they're so soft, the Nelaton Tim and Tip or Coude tip, sometimes that's just an in out if you to buy time, and that's something that we've done in the community in the past to just to buy a bit of time to get them to hospital. Yeah,
I tend to if the GPs aren't comfortable with those things, I tend to be a little bit reluctant to advise those sorts of things, because urethral damage, causes a lot more hassle for us. So I tend to sort of, if you're not comfortable with the catheter and it's not going in, I don't like to try sounds or introducers or things like that. What I do, which I use a flexible wire and railroad a catheter over it, just like a Seldinger technique. I don't use an introducer. Now, whether you're comfortable doing that or not, I don't know. There was a case at Royal Brisbane where someone managed to get that wire into the rectum and railroaded a catheter into the rectum. So I think you've got to be a bit careful doing that. But if you're using a very flexible wire that they use for central lines and arterial lines, and you're confident you've got it in the bladder, you can just railroad a catheter over that. That's another technique.
Most rural hospitals have got suprapubic kits. I think it's something that's essential to learn as a rural GP registrar, and I think this harks back to the point about catheterisation in general and rectal exams. I think more and more we're seeing people coming out of hospitals with fewer and fewer procedural skills. I think it's really important for the registrars to take it upon themselves to make sure you get exposed to these sorts of procedures in the hospital, so that when you do get sent out to Cunnamulla and it's the middle of the night and this happens to you, that you've got some skills up your sleeve. If you're getting to the edge of your skill set with these things, my first thing to do is get on the blower and get Jake on the phone and say, well, what would you do here as well? But it's that you still need those physical skills to be their hands remotely. So you still need to have at least some exposure to some of these things. And you don't have to be completely competent to actually provide a good service in terms of being, the best guy at doing that. But that's the risk and the challenge of being a generalist, is that we often are put in the position where we have to do skills that are on the edge of our competency. But you still, I still think it's really important to build up your repertoire as best you can, so that in those sort of situations with advice and with support, you can still effect good treatment remotely. And that goes back to the prostate exam as well. I think people are getting shyer and shyer at sticking fingers in holes, and I think it's really, really important to get as much exposure to that as you can and not be shy. I think in the day and age of ultrasounds and scans and tests, people think they can get away with that sort of thing. I think it's really, really important that we still go back to the important clinical things that are simple. And going back to that, I'd just like Jake to give us his spin on what he thinks the best thing for screening is, because in general practice, we get a general practice magazine every week telling us to screen and then not to screen, and I'll be interested to see Jake's contemporary view on the role of screening and PSA plus or minus the rectal exam.
Yeah, the GP colleges and the Urological Society have very differing views on this, but my society's recommendations are that all men at the age of 40 should have a single PSA test. If that test is below the median for their age, which for a man from 40 to 50 is 0.5, they don't need another test done until they're 50. And at that point, from the 40 to 50, I don't think there's a lot of value in doing a rectal exam, particularly if their PSA is below 0.5. If they've got a family history and they've had cancer diagnosed in a close relative, they should start screening 10 years before that relative's age of diagnosis. So, for example, if their father was 48 with cancer, they need to start screening at 38. Once they get to 50, my feeling is that men should have a PSA test and a rectal examination every year. The rectal examination, I think, is important. I would see one patient every 2 or 3 months that's got a PSA of 2 and a horribly malignant feeling prostate. And if you're a GP just doing a PSA test, you're going to miss them. And they happen because they're non-PSA secreting tumours. So the value of the rectal exam is really important, because you will miss one in your careers if you don't do it. I think it's important to counsel patients before you start screening. I think it's important to say that if this is elevated, this is where we could be going with this, And the patients themselves might say, well, hang on, I don't want to know. There's a prominent urologist on the Gold Coast who's 70 who's never had a PSA test and doesn't want one because he doesn't want to deal with the consequences of screening. And that's an individual thing. And some people think that way. So I think you have to talk to them about where it's going to lead. You might need a biopsy, you might need to have your prostate out, and that could involve, loss of sexual function, those things. They need to know a little bit about where they're headed if you're going to start screening.
All right. Any more questions?
Actually, I've got one, Jason. If it's a low PSA admitting cancer and it's removed and it metastasised, like it escaped, will it always be a low?
Yes.
Admitting? So it could have small numbers but still be quite.
That's right, and
growing.
those patients become very hard to follow because we use PSA as a very sensitive tool for cancer recurrence, and they become difficult management problems. They often need a lot of extra scans and things to pick up their cancer that may have spread.
Hi, sorry, I've just got a quick question related to your screening comments. Based on those recommendations of every 10 years, when should you stop screening, just with your comments before about the elderly patient?
Good, very good question, and that's the point Scott was raising before. I tend to say that that's a very individual thing. If you've got a 70-year-old chap that's got diabetes, high blood pressure, he's had his cabbage done 10 years ago, I think you can probably stop him at 70. If you've got a 75-year-old that's on no medications, that's out and about, and he's got 10 or 15 years of life expectancy left in him, he probably does still need to be screened. So I think it's an individual thing. I tend to think of it of what do I think my life expectancy of this guy is, and if you think it's more than 10 to 15 years, they probably should still be on screening. That's my rough rule.
Good. Any other questions from our audience? No? Well, I think that's been a very informative and interesting case in urology tonight. Can we all please thank you to our specialist and expert panellists for tonight, and can we thank Edan for his excellent case presentation?